All right, good morning, everyone. This is Stephanie Baker, the Senior Program Coordinator for Massachusetts. I am involved in our care transitions work for the New England Quality Innovation Network Quality Improvement Organization, and I'd like to thank you for joining us for today's webinar entitled Using Innovative Approaches to Promote Palliative Care for Your Patients. But before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes, and the recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute during the presentation, but we will unmute the lines after the presentation for questions. I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we still would like you to actively participate during the session by using the chat function. My colleague, Annie, will be monitoring the chat window and responding to your comments in real time, so don't be shy. We'd love to hear your thoughts about what our speaker is saying and how you are addressing your palliative care needs in your practice. Our present presenters come to us today from the Health Policy Commission's Healthcare Innovation Investment Program, which is a unique opportunity for Massachusetts providers, health plans, and their partners to implement innovative models that deliver better health and better care at a lower cost. The state's landmark cost containment law established this competitive investment program to support healthcare innovation and transformation. The first phase of the Healthcare Innovation Program launched in the summer of 2017 and includes over $11 million in investments to 20 competitively awarded selected awardees across Massachusetts. Awards are divided among three different pathways: the Targeted Cost Challenge Investment Program, and the Telemedicine Pilot, and the Mother and Infant Focused Neonatal Accident Syndrome Interventions. Today, we will be hearing from two Targeted Cost Challenge Investment Programs. The goal is to support innovative delivery and payment models that are poised to be taken to scale and make a meaningful impact on healthcare cost growth benchmark in years to come. Eligible applicants and their partners propose initiatives that will reduce the cost of care to the healthcare system while improving quality and access in 8 priority areas of spending. For our learning objectives for this program, you will learn to use shared strategies to engage in advanced care planning discussions with all patients, describe how these programs identify patients who may most benefit from palliative care, and recognize how community providers might help to promote palliative care support and services you can offer your patients. As I shared, during this call, we want you to use the chat feature so that we can hear from you. So when you chat in, please make sure you click all participants so that everyone can see what you're saying. So let's test this out by telling us who you are, what organization you are with, and the state that you are calling in from. I'd like to introduce today's speakers. Today we will be hearing from Eileen Fagan. Eileen has 34 years of nursing experience with greater than 25 years focused on community health, palliative, and hospice care. Eileen obtained her Bachelor of Science degree in nursing in 1984 from Regina University in Newport, Rhode Island, and her Master's of Science degree in nursing from Endicott College in Beverly. In 2006, she completed the Harvard Medical School Palliative Care Education and Practice Program and has been with North Shore Physicians Group since 2010 with the launch of the Medicare Demonstration Project, embedding case managers in the primary care practice. She also led multiple team projects regarding advanced care planning, integration, and primary care, and directly provided the end-of-life nursing education support and training for all chronic disease care managers across Partners Healthcare System. In 2016, Eileen moved to a primary care provider role, and in 2017 became the Palliative Care Coordinator for North Shore Physicians Group as part of the state-funded grant program with Care Dimensions. In this role, she is coordinating, teaching, and supporting all other practices to expand knowledge, understanding, and utilization of palliative care for this population of patients. We'll also be hearing from Susan Hurley. Susan is the Director of Research at Care Dimensions. Care Dimensions was originally the hospice of the North Shore. Susan began working in palliative care 14 years ago as a palliative care nurse practitioner after graduating with a dual degree in gerontological nursing and pastoral ministry from Boston College in Chestnut Hill. She then pursued her doctorate at the University of Pennsylvania School of Nursing, where her training and dissertation research received funding from the John A. Hartford Foundation and the National Institutes of Health. In her current role, she directs grant activities and serves as a site coordinator for all research conducted at the agency and is pursuing additional academic partnerships and grant funding. Dr. Drew Kathari, in addition to leading quality improvement and clinical efficiency projects at Commonwealth Community Care, is a practicing physician. He is the primary care physician for a panel of socially vulnerable and medically complex members at Commonwealth Community Care, and is an attending hospitalist on the Commonwealth Community's inpatient unit of Boston Medical Center. Prior to his tenure at CCC, Dr. Kathari worked in rural Nepal, leading health economics research agenda and their public policy initiatives. In addition to being an internist, Dharuva is also trained as an economist and spent 2 years working with the J Poverty Action Lab as a research economist in India, Morocco, and at MIT. Dharuva is passionate about improving the psychosocial outcomes of the most vulnerable patients in the U.S. and globally. Dharuva received his undergraduate degree in economics from Harvard College and his medical degree from Columbia University, College of Physicians and Surgeons. He completed his residency training at Yale New Haven Hospital. And we will also be hearing from Dr. Tom Petit. Tom is an internal medicine physician and lifelong educator. He received his BA in physics and philosophy from Wesleyan University and substantially taught math and special education in St. Louis with a Teach for America. He graduated from the University of Massachusetts Medical School and completed internal medicine training at Boston Medical Center. He is currently a primary care physician at Commonwealth Care Alliance and completing a rural health fellow at Massachusetts General Hospital, where he is an assistant in medicine at Harvard Medical School, focusing on medical education, primary care reform, and addiction. So we have a great experience on our speaker panel today. So just to get us started, and before I turn it over to our speakers, I wanted to set up some background information. As described by the World Health Organization, palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness, through the prevention and relief of suffering by means of early identification and assessment and treatment of pain and other problems, physical and social and spiritual. Palliative care provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. It intends neither to really hasten or postpone death and integrates the psychosociological and spiritual aspects of patient care. It offers a support system to help patients live as actively as possible until death, and offers a support system to help the family cope during the patient's illness. It uses a team approach to address the needs of patients and their families, including counseling if indicated, and will enhance quality of life and may also positively influence the course of illness. It is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications. In a study providing palliative care across the continuum to reduce readmissions from the community settings by Kelly Baxter, it was aimed at improving transitions of care and reducing hospital readmissions for patients receiving an inpatient palliative care consult at one hospital. They found by partnering with their health system's community palliative care team, it allowed them to extend palliative care into partner facilities via a palliative nurse trained in communication skills to facilitate the transition of patients to hospice or community-based palliative care services as appropriate. Over the course of this year-long project, readmission rates for all palliative care patients decreased from 22% to 16%. In particular, readmission rates of patients being discharged to partner facilities decreased from 26% to 10%. So why it matters? Palliative care helps to align patients' medical treatment with their goals. It improves outcomes for patients by providing comfort through symptom management, helps avoid unwanted transitions of care and readmissions, and potentially reduces unnecessary healthcare spending. So we would like to hear from you. How are you addressing your patients' palliative care needs within your own organizations? I'd like to now turn it over to Dr. Dhruva Kathari and Dr. Tom Petit from Commonwealth Care Alliance. They'll be sharing their innovative approaches to how they've integrated palliative care into their organization. Dr. Dhruva Kathari.
Hello, everyone. Tom and I would like to begin by first thanking the New England QIO for having us, thanking you all for being here to listen to us, and really thanking the HPC for providing us the funding and the support to make this a reality. We're really excited for the next 15 minutes or so to share with you our primary palliative care intervention, how we set it up, and why we think it provides such value to clinicians and our members. So the agenda for today, we're going to start with who we are at CCA and who are our members. We'll then segue to a typical member and her story. And then hopefully, in all your minds, as you begin to hear about this typical member, you'll begin to understand why we implemented the intervention that we did and why we shaped it the way we did. We'll then talk about how we put it into practice, especially for you guys out there who want to set up something similar. We want to sort of share the nuts and bolts with you. And then we'll finish with how the intervention impacted this member, and then also data and lessons learned. Who are we at CCA? We're a payer provider that takes care of dual-eligible Medicare and Medicaid patients. We are the insurance company and the care provider for about 27,000 members across the state of Massachusetts. They fall into two buckets. Our over 65 members, they're taken care of in a program called Senior Care Options, and our under 65 members are taken care of in a program called One Care. Our members are very medically complex, they're very psychiatrically complex, and they have a ton of social complexity, especially on determinants of health. They also have often significant functional limitations. Another way to say this is that, per member, we receive $45,000 on average per member per year to take care of their needs, which is greater than 10 times the average of the standard low-risk Medicaid or Medicare members. Both our One Care under 65 and our Scroll over 65, we found, have had significant palliative care needs. What makes us special? If I were to distill CCA into sort of one phrase, it's that every member in our organization has their person. We call that person the care partner, and their care partner is responsible for longitudinally helping that member meet all of their needs. Our care partners operate within an MOU of different interventions that we designed to meet different members' needs. One of them that we'll be focusing on here, since our primary palliative program was set up within that, is our home-based chronic care, where our most complex, our most sickest members come, and their primary care team, which is a physician and an NP, can meet them where they need to be met, whether that's at home, a shelter, on the street, in the clinic, and take care of their primary care there. We really believe strongly in primary care. We invest 10 to 15% of our premiums in that. And the primary care team I mentioned, the physician and NP, has the support of a broad interdisciplinary team to help take care of each of our members. Those include behavioral health therapists. Those include community health workers, physical therapists, DME experts, nurses. And all our clinician types have been designed to flex so they can provide same-day care for urgent needs both at home or the clinic. Our members are sick, they get sick all the time, so we've set up our practice. We can do home visits, 18 hours a day, 7 days a week, when urgent needs arise from our members. And taken together, it forms this radical premise where we try really hard to save money on wasteful acute care utilization and pump that back into members to keep them happy, healthy, and well at home. So now that you've heard more about us, let's segue to a very typical member of ours, Deborah S. The pseudonym, she's a composite of two different members. She's 59 years old. She's bipolar, polysubstance use, COPD, coronary artery disease, chronic pain, and she frequently falls and is occasionally forgetful. So as you can see, she encapsulates all the different types of complexity that we see. Medical, psychiatric, social, and she has functional limitations. She's a typical member of our home-based primary care practice, and she's been with us for 3 years. Coming into our practice, it probably resonates with a lot of you out there. She's, with her complex needs, she's been often in and out of the medical system, and has had some tough experiences with them, so it's hard to earn her trust. But luckily, within the 3 years that we worked with her, she was at the same set of providers, and over that time, we had the privilege of earning her trust. Unfortunately, soon after coming, she was diagnosed with cervical cancer, which unfortunately metastasized despite aggressive treatment. Now that you've heard about who we are and a typical member, I think it'll make more sense to you why we chose the intervention we did. So what is primary palliative care? Very simply, it's a process that equips primary care clinicians with very real, very thorough palliative care skills. And why do we choose this intervention versus an intervention where we refer out to palliative care experts? So, as you can see in the case of Deborah S., our members, through the medical system or through their day-to-day life, have often suffered significant trauma, which makes it hard for them to form trusting relationships quickly with people. We're able to bridge that, but it takes years, and it takes years of working intensively with our members in close partnership. And our members often don't do well when they're sent out, when they're referred out to see specialists that they meet very briefly and very infrequently. We also noted that the majority of our end-of-life diagnoses, they don't have discrete onset. So there isn't a moment where, it's time to switch 100% to palliative care. Instead, as our members approach end of life and their disease state, whatever it is, progresses, the mix of primary care and palliative care we do changes. And the intensity of palliative care increases and the intensity of the primary care diminishes as time passes. And throughout that process, there are elements of palliative care that need to seep into our daily practice. And our members with the functional limitations, they require a lot of care. Our clinicians often are meeting our members once a week, and that model doesn't work well for palliative care experts who operate on the model where often they'll see members for 20 minutes sort of once a month. How do we make it happen? The core part of our course was a 5-hour course taught over 3 weeks, taught by Dr. Petit. You can see the syllabus on the right. And one thing I wanted to stress is that it covered all the core palliative care topics that were introduced earlier in this hour. And we also didn't roll it out and then forget about it. We hold annual refreshers. Dr. Petit held it this year, back in February. And we embedded palliative care rounds into our team meetings. So once a month, we track cases to do our monitoring evaluation that HPC helps support. And we also discuss complex members to provide support, but also to provide continuing education. Being a payer provider gives us the ability to flex our schedule, so our members, our clinicians are able to spend much more time with members that need their care, which we often see in our palliative care members approaching the end of life. And our clinicians are able to tap into formally trained palliative care experts. They can do that in person or telephonically. And again, a plug again for HTC, is their sort of grant and their funding that allowed us to implement this course and this intervention. So we're very thankful. So now that you've heard more about the course, how it was implemented, what we taught, and how it was integrated into our practice, let's revisit the case of Deborah S. And we can see how the different trainings played out in her life. So the flexibility that her schedules, that our care model allowed her primary care team, in this case her NP, to co-attend her oncology appointments. And there came a point where the palliative chemo, the benefits outweighed, the cost outweighed the benefits, and we're able to help advocate for Deborah that, it's probably time to stop that. The primary care team really leaned on sort of the teaching that was done on difficult conversations. And we were able to elicit that at the end of her life, Deborah wanted to die at home, surrounded by her 2 cats. And under no circumstances she wanted to be even in a hospice home. And fortunately, we're able to petition the insurance side of our company to authorize 24-hour care at the end of her life through a PCA program. Deborah was actually closest to her community health worker, and the community health worker sort of came from that neighborhood, so she was able to find the PCAs to staff those hours for the last 2 weeks. We were able to address both Deborah's but her family's spiritual and emotional pain. And thanks to the medical training we got, we placed a comfort kit in. The primary care team plus the on-call team managed her pain with fairly sophisticated dosing of a fentanyl patch and sublingual morphine, and her nausea and anxiety were managed with different meds administered to different routes, depending where she was in the dying process. And while we as a practice are very sad to lose her, we were very proud that we gave her the death that she wanted. She died at home with her cats in her bed, and she even got the tattoo that she really wanted at the end of her life. So let's segue to outcomes. We have process outcomes to share. What you see here is results of a test that we administered before and after the course, and what it shows is both statistically and clinically significant improvements in knowledge in 3 of the core areas that we addressed in the course. We don't yet have volume or outcome data, but with HTC's help, we're collecting that, and hopefully we'll be able to share that in the next year. And finally, lessons learned. Especially relevant to you out there, we'd love to support you if any of you are interested in creating an intervention like this in your practice. We really feel that this intervention needs to quadruple aim. We only have hard data on really clinician empowerment and satisfaction. That's part of the data I showed you on the last slide. We have anecdotal evidence that we need the other 3 parts, and we're collecting some of that evidence. This intervention works very well for patients that have very complex needs and ones that especially have functional limitations too, and ones that have a tough time creating trusting relationships quickly with people in the medical system. Equipping busy primary care clinicians with real, tangible specialty skills seems like a daunting task, but I want to assure you all it's possible. We did it, you can too, and we'll share our contact information in the next slide. And we'd love to sort of help you guys do it too if you're interested. One big takeaway we learned was that you can't just roll out a program like this and expect it to succeed without active management. We really were thoughtful about embedding it in basically in the structure of our clinic, both through team meeting and with periodic training. And for those clinics and clinicians out there that have flexibility in their schedules, I think that gives us the greatest chance to succeed. And with the ACOs rolling out in Massachusetts, and probably around the country, I think a lot of you are parts of clinics that have increased flexibility to make this success. I want to end with, again, thank you all for attending. Thanks to the QIN-QIO for hosting, and we're indebted to the HPC for the funding support they give. I want to share our contact information with you, and feel free to contact us if you have any questions.
Great. Thank you very much, Dr. Kasari. And that was a great presentation. And if anyone has any questions for Dr. Kasari or Dr. Petit, please feel free to chat them in at this time around their palliative care curriculum. So now I would like to introduce Susan from Care Dimensions and Eileen from North Shore Physicians Group to hear how they've integrated palliative care by working together as community partners. And Dr. Kasari, if you could just pass the ball to Susan.
Yes, will do.
All right. And then Susan, to unmute, you just press #6.
Great. So thank you and welcome. We also are very grateful to be here to be able to talk about our project. And thankful, especially to the Health Policy Commission for the funding and trust and support as we moved along in this program. And we're excited to tell you all about it and happy to take questions as well. So first, telling you a little bit about our organization and who we serve. First off, Care Dimensions, and for those of you who are not familiar with us or the area here, we're a not-for-profit provider of hospice. The largest not-for-profit hospice in Massachusetts. We serve, as you can see from the map, a real wide range of communities, urban, rural, and suburban mostly. We've cared for 4,900 patients in 2017. Some of you may have heard of us. Originally, we were Hospice in the North Shore. After acquiring Partners Hospice in 2011, we then changed our name to Care Dimension to represent the range of communities that we now serve. Our mission is to enrich the quality of life for those infected by life-limiting illness. We take care of patients along the spectrum of life-limiting illness, from diagnosis through our palliative care team, through hospice care, for very end-of-life care. And as folks hopefully know, hospice is provided by an interdisciplinary team. It includes a physician, nurse, chaplain, social worker, 8 hospice aides. We have a variety of complementary therapies from pet therapy, music therapy, art therapy, and child life specialists to help when patients or families have young children in the home. And then we also have volunteers, which is part of the Medicare hospice program in general, providing a fair amount of help. Just to give a sense of the size, we have approximately almost 800 patients a day, and most patients are served at home. We do have a fair amount of long-term care and assisted living, and we made over 2,000 palliative care visits in 2017. We also have, for those patients, not everyone can die at home, and not everyone wants to be honest. We have 2 homes. We have one in Danvers and one in Lincoln. They provide an inpatient level of care, but in a home-like environment for acute pain and symptom management that can no longer be managed at home. And they have all private rooms with living rooms and some family areas for family to be together while the patient is undergoing treatment and therapy. We're delighted to be partnering in this initiative with North Shore Physicians Group, which is a multi-specialty group practice affiliated with the North Shore Medical Center and Partners Healthcare on the North Shore here. They have over 275 physicians and nurse practitioners and other healthcare professionals that treat patients in 12 locations here. North Shore Physicians Group serves about 18,000 patients in the North Shore area, and about a third of those are older adults. The really wonderful part about this initiative has been this partnership that was actually building on collaborations we've done in the past. We've been collaborating for over 20 years for patients with serious illness for hospice and palliative care. Specifically, we worked with North Shore Physicians Group as they did the Medicare Demonstration Project for high-risk Medicare beneficiaries, the ICMP program, and they have helped and collaborated with us on the Medicare Care Choices model, of which we are participating in still will for another few years. The Palliative Care Plus program, which is the grant initiative that is funded by the Health Policy Commission, is aligned with institutional goals, both for care dimensions and Northwest Physicians Group, which when you think about rolling out a program like this really helps a lot. In general, they both meet the mission for both institutions, and that particularly for Northwest Physicians Group, there's been some work on internal performance and some framework measures that they are adopting for best care for patients with serious illness in general at their institution, and then help meet those and so it's carefully aligned. So the problem that we were addressing here is in general, many patients with serious illness experience unwanted hospitalizations and emergency department visits toward the end of their life or during diagnosis, anytime after a diagnosis with a life-limiting illness. And these unwanted hospitalizations and emergency department visits contribute significantly to overall health costs. And often we find that patients are referred towards the end of life versus a little bit earlier when perhaps we could establish a relationship and help patients in their process a little bit earlier. So in general, our principle is that palliative care service can increase quality of life and reduce costs by providing the care aligned with their goals, especially if they're referred a little bit earlier. And one of the best ways to do that is to try to work within primary care networks because patients are seen there very often and known there, and they can help refer. So our real goal was to raise awareness within the primary care setting and begin to have folks in the palliative care program to be able to start to work on what's most important to them and their quality of life. Eileen's going to talk a little bit about the intervention.
Hi everyone, this is Eileen. So again, going over the project summary, our goal really was to say that similar to what you've heard earlier is to embed palliative care support into the primary care practices. And I'm going to get into a little bit about that under the how slide. By providing a resource for primary care physicians in real time with the early identification of patients and serious illness. Who are these folks? Again, I'm going to address that under the how. Therefore, establishing palliative care for patients far earlier than hospice eligible, which we know in the sort of practice of life that it has been, that's when palliative care gets thought about. Like, oh, how about now? When patients are really eligible for hospice at that point. And have had unwanted care. So we're really looking towards improving patient quality of life, clarifying goals of care, prior to an acute crisis, prior to that unwanted emergency room department and inpatient stay, where those needs get addressed because the crisis has to come forward. So again, we wanted to try and change that practice. So our primary aim was to decrease by 20% all cause readmissions, inpatient readmissions and emergency department visits for the enrolled population in the Palliative Care Plus program, which we're calling it Plus because it makes it a little bit different than the typical palliative care that would have been referred to. And that's specifically what this grant structure is. So we also are looking at increasing the hospice length of stay for North Shore physicians who patients served by this grant. And that is internal framework for North Shore Physicians Group as well. So the how is really where we really focused our teamwork and our ideas. Is the first step was really looking at palliative care screening worksheet or a tool. How do we make aware in the day-to-day operations of a primary care practice what patients might be eligible for palliative care consults and conversations, goals of care, etc. And we really worked on tweaking that tool to mirror the flow of a primary care practice. We were able to develop in our EPIC eligible report section, which is on EMR, patients who may have had activity that may, kind of identify them as someone who has a need, but then that becomes a conversation between provider and the chronic disease and the serious illness nurse to see how the patient and family are doing. Directives and referrals right from the EPIC order sheet in the practice with PCP to the palliative care coordinator, which is myself, and then I take that further with patients and all the team involved with them. And direct care coordination with the inpatient consult team. So we really try to link more consistently our primary care outpatient team to the inpatient team, and direct care coordination with the NSPG rehab team. So we've really pulled in all of our North Shore Physician Group teams that work to support patients into this project as well. So if you look at the flow, it's really patient identification into the home-based palliative care, and this is the work of the palliative care team. The NP goes out to the home, does the consult, and coordinates the plan of care. Addresses advanced care planning, gets enrollment forms done, discusses patients bi-weekly with an IPT meeting. There's a palliative care RN who does support telephonically, guiding patients' wishes, whether it be weekly or bi-weekly or every other week, to really identify any symptoms that are sort of percolating that we can address early and have both teams work towards solving. Telehealth, 24/7 access to triage, and a dedicated social worker for emotional support. And those patients during that process who need to transition to hospice early or who are ready for it, right through the support and the early identification of your primary, the team at home, we really have been able to help patients have a softer landing as opposed to, that really turbulent landing that happens currently. So our timeline, the preparation for this project started, and the pre-work started in November of 2016 and rolled into May. We began the program in the primary care group June 1st and will finish June 30th of this year. So the staffing model is dual teams. It is Care Dimensions and North Shore Physician Group. So the Care Dimensions team has some nurse practitioners, the RN coach who does the telephonic, social worker, medical director, provider relations team does help support education and materials for our primary care practices, data analysis, and the project director. Under the physicians group, we have myself, who is a full-time, and I do on-site one day month in each group. We have medical director, associate, and a project director. The target population, obviously, our eligibility really ones where we get a lot of work. So it has to be a North Shore Physician Group patient who is part of the accountable care organization that's identified as a Medicare and have a life-limiting illness. Referrals come to us in a variety of ways, direct from the NSPG primary, the Care Dimensions Provider Relations team, screening for all palliative care patients who are referred, like we said, comes in from a different source, but there's a North Shore Physicians Group primary or secondary physician, and any patients that do not go on to care from Care Dimensions or hospice referral, that does meet the grant criteria is put into the project. So our enrollment goal is to see patients within 5 days of connecting with the family. We really established good clinician-to-clinician communication between the palliative care NP and a nurse at North Shore Physicians Group, whether that be a serious illness coordinator nurse or a nurse in the practice. We have maintained that nurse-to-nurse coordination. The biggest hurdle we have found is that patients who are clinically eligible, who meet the criteria that we've educated for, do have Medicare but do not fall into the ACO. So that's really, we have to put them in the regular palliative care track. Patient engagement is really the process of starting this palliative care at home. The nurse practitioner again goes out, addresses the need, communicates back to the primary clinician. If there's an advanced record that's completed, that is then put back into the primary record as well as the palliative care record. The patient does get referred on to the nurse coach and the social worker to help with those regular monitoring needs. And telehealth, if possible. There are 10 telehealth units that we have that are all being used, and there is actually a waiting list. And I was looking for one this morning, and there's a waiting list. So that has been a great success. The communication back with the North Shore Physicians Group providers and the nurse case managers there's really a lot of care coordination that goes on that really gets patients into the office, that gets patients when a evaluation of symptoms happens. There's a nurse practitioner or two nurse practitioners, both groups working together with the PCP to help, identify and kind of quiet some of those symptoms, come up with interventions in real time that can avoid any unwanted care. So the phone calls are great. The routine care continues with the primary care team. Patients can come in, they can have their doctor visits, and our transition to hospice care when appropriate. But again, we really noticed that soft landing has been really a great part of what this department has helped provide patients and families. Again, the 10 telehealth units we have available for patients with CHF and COPD, and patients really engage with that. And I was talking to one of our high-risk nurse care managers this morning, and she was saying her patient really has gone out and started planting flowers because the compliance has been so much better with its management through the telehealth and the Palliative Care Plus team. She said she's known him for 5 years, and he always wanted to go out and plant flowers in the spring, but this year actually did it. So it's been a really great, positive thing for patients.
Great. This is Susan again, and I'll just tell you a little bit that for sure on our results is an ongoing evaluation. We are still in the process of doing all of the data analysis by each quarter, and so we'll have more results in a year as well. We certainly had a high number of referrals, likely limited for admission to the actual program, but all the patients that are referred to get palliative care services. We have definitely seen a more integrated partnership, even for companies that have agencies that have been working together for 20 years. The addition of more support, more communication, a real focus project has really elevated the communication and the relationship in general. We're beginning to see some culture changes, particularly in the primary care offices, about requesting some assistance when they know they have a patient who might warrant extra services or might be at a place, and having them pick up the phone or send an email to request some help with how to have a conversation, what are the options available. So we've definitely seen that. We've learned some lessons around population identification, really trying at the national level this is happening as well, who benefits the most from palliative care services and where can we have the most impact. And then also we've done a lot of work around mold forms across the electronic health records, which I'll talk a little bit more about. So for those not in Massachusetts, we have a mold form as a medical order for life-sustaining treatment, which is valid in Massachusetts across settings. We have had a significant advancement in tracking since the start of the implementation period for our grant. We didn't have any baseline to track that. We were tracking the ICD-10 billing code, but we really thought that as meaningful as that was, what's more meaningful is whether the mold form is in the chart for the right people to be able to use it. And so now we're tracking the copies of that document. And we've also started to work around HIPAA-compliant photos in the home to be able to move that scanned document where it needs to be. One patient story for us. This is a gentleman who had had a whirlwind, medical visit that began approximately 5 years ago with a fall and diagnosis of cancer. And his functional status and medical needs became so great that he moved in with his family in 2017. But soon after that, began experiencing pain and more trouble walking. His primary care recommended a Palliative Care Plus consult and enrollment in the program. Through his involvement in the program, he had a nurse practitioner visit to assess the pain and overall functioning and the goals. And the palliative care nurse coach called to check and reported the findings back to the palliative care nurse practitioner as well as the NSPC physician, kind of keeping that loop of care where it needed to be. And the patient did improve some, but was resistant to a lot of changes. And after the patient did return, he made another visit and was able to titrate the pain medication where it needed to be. And so finally the patient reported the pain was less, they were sleeping, eating, had more social engagement. And so it really had a much stronger and better quality of life for a few months. And while it improved him, together with his family, he did decide that hospice care was the next logical step. And he came on to hospice, which was made a lot easier through the early introduction that Eileen talked about as well. So again, thank you for having us today, as well as to the HCC for their support, and here's our contact information in case we can be of any further service.
Great. Thank you so much, Susan and Eileen. Great presentation and how you've worked together to really integrate your palliative care for your patients. And so now we are going to take the opportunity to open this up for discussion and questions. And just as a reminder, if you want to ask your question over the line, you just need to press #6, and that will unmute yourself, and then you can ask your question there, or you can feel free to chat it in. So I'm actually going to see if there's any questions in chat. Annie.
Thank you. Yes, we've got a few questions on chat. So the first couple refer to integration with hospice. So I'm going to direct these to Dr. Katari and Dr. Petit. I think they're referring to their portion and kind of the connection with hospice and how that works into your program.
Yes, hi, this is Dr. Katari. I think it's a great question, and actually, if we go deeper into Deborah's case, really in the last few weeks, we did also supplement care with a home-based hospice agency. But with so many of our members who don't have a ton of their own support, there's a few thoughts around that. So one is a lot of our members don't have their own support. The hospice isn't enough to provide all the care, and our wraparound ability to augment hospice's care we find to be very invaluable in supporting our members' needs, whether it's sort of at a home, especially at home. And then second, there's a lot of intricacies with their case. I didn't mention all of them, but a lot of the work that, a lot of the skills that Dr. Petit taught to our clinicians, really came into play even before she entered the actively dying phase, from sort of holding skill discussions, teasing out wishes, to addressing goals of care, to addressing the first onset of symptoms before she entered the actively dying phase. So a lot of the value of our program actually can occur before you formally enter hospice. And then lastly, a lot of our members, it's often not, right, if I remember this correctly, if you want to go into the Medicare, I think this is another question, the Medicare hospice benefit, you should give up the right to curative services. And for a lot of our members, it's not as black or white for that, for the bulk of their disease process.
Great, thank you. We're just going to take this chance to see if there's anybody on the line that would like to ask a question. Yep, great.
Sure. We will go back to some questions in the chat. We have this question in from Karen. Does Medicare pay for palliative and/or hospice care at home or in the hospital, at the hospice facility, or at a SNF? I could see cost being an issue as to why families don't want to give up the rehab component of a stay to convert to palliative or hospice care if not covered.
Go ahead.
This is Drew. I think they pay. I think it's sort of specific on what they pay. I think they pay for some a limited amount of all of that. And again, I think Deborah's a great example. Sort of this member where she just didn't have enough family support. She had a sister that was very close, but was, I think, experienced a lot of caregiver fatigue. So they would pay for home hospice, but not enough. I think not enough in our case to support someone who's actively dying with very little of their own support from their loved one.
This is Susan. And so the Medicare reimbursement for hospice, it is setting dependent, and so patients can be served at home, and they can have some aid services, 24-hour care if they need that level of support. You can have continuous care at home for a short period of time that hospice does reimburse. There's 4 So in general, there's 4 levels of reimbursement: home care, continuous care at home, inpatient level of care, and then respite care. So if caregivers need a break, then there's a 5-day respite for every certification period. So hospice, yes, is reimbursed in that way. And when someone is in a skilled nursing facility, you're correct that usually they need to, or they wouldn't be on their SNF benefit when they were in the SNF. It would usually be when they came off, when they were ready to come off of their SNF benefit, that they would be able to come on to hospice. And a lot of that is somewhat financial, but it's also just the goals of care. If someone is really in a SNF and looking towards complete and total rehab goals, then that isn't really aligned with just focusing on comfort care or just quality of life. And so the payment model for palliative care in the past has been really through Medicare Part B billing. So in the same way that a cardiologist or an oncologist bills, that's how palliative care billing has been done. So it's been at the advanced practice level. And the good news is that when someone is at a field rehab facility on their SNF benefit, they can have a palliative care consult because that's billed through Part B the same way they would go see any other specialist. So does that help answer the question? For people that are particularly interested in this, there are a couple of models being presented at Medicare at CMS right now looking to think about palliative care payment reform.
Great, thank you. Another question for the Care Dimensions team. Do you get primary care okay for all the Care Dimensions NPs in-home consults first, or do they just report back to the primary care physician after the in-home visit?
So we need an order, and that's for a couple of reasons. But the strongest reason is that we want it to be a joint team effort to take care of this patient, and in order as a way of communicating and inviting you to participate in the care of this patient. So no, we require an order to be able to see that patient.
And on the provider side, for the providers to be part of the initiation of palliative care, as an intervention for the patient, it allows them to really maintain that physician-patient primary relationship too. So that's really important for the providers from the physicians group as well.
Great. And is there anyone on the line that would like to ask a question? And just as a reminder, #6 to unmute yourself. All right, we'll continue.
So getting back a little bit to kind of credentialing and billing, we have a question getting into some of the specifics of how the NPs are credentialed as part of the team and how that more structurally folds in, and who bills for the NP palliative care service. If you could give us some more detail on that.
Sure. So I think what you might be getting at is credentials with it. So our palliative care NPs are employed by Care Dimensions, and are they credentialed at North Shore Business Group? They are not. Some of them happen to be credentialed at North Shore Medical Center, just as a part of the wider agency structure, but they are not that. It's a separate organization, so they're not credentialed there. So they are not considered part of the practice team, but I would say they're very important to consider part of the team caring for those patients. So, and because of the relationships of the NPs and the palliative care coordinator there, and the case managers and the providers over at NSPG, there are very strong partnerships, but not sort of structurally part of that team. And then the billing for the NP palliative care service comes out of Care Dimensions as part of the way that we structure the Medicare Part B billing for palliative care.
And the visits are done at home.
Yes, the visits are
not done in the practice center.
Yes.
Great. And Dr. Kathari, I don't know if you wanted to chime in on that, or we can move on to our next question.
For us, sort of billing is a little bit simpler. We're our own care provider, so we do more tracking to sort of demonstrate value back to Medicare, Medicaid. But with kind of nice about it is we don't have to sort of build to generate traditional revenue. And, you know, since our program is a primary palliative care program, it's the primary care agencies that do that. They get the standing credentials with us, and they're part of our, I mean, they're essential to the team.
Thanks. So we've got some good points from a participant talking about the importance of pharmacy involvement and the importance of a pharmacist to help manage these vulnerable populations and work with the team on med management. Wonder if any of you would like to comment on how you interact with pharmacists in this work. Also, as another part of this question, sort of thinking again about the importance and role in the home in terms of kind of identifying and supporting patients who may be in less than optimal home conditions and how the team may address that. So a little bit of a two-parter if you wanted to comment on the pharmacy involvement and also some of those aspects of the home visit.
I'm happy to speak a little bit. That we actually, in the last year, hired a full-time pharmacist for our agency, so we do have pharmacy consultation available for these patients because you're right, they're very medically frail, fragile, and we're often talking about symptom management medications that require careful titration and consideration for polypharmacy, which is usually also something that our patients are living with. Yes, I would say that particularly for patients that may be living in conditions in their home that are not optimal, that we have a couple ways to address that. One, certainly when the nurse practitioner makes a visit, if there's something that she finds that needs more assistance. Often these patients also have visiting nurse services, so some of that is coordinating with the visiting nurse service about education. And then the other thing is that we have a social worker on the team who makes the visit and can help make some referrals back to your referral physician group to help coordinate, but also to help them with community resources.
Thank you. It looks like we have time for one final question, so really appreciate all of your participation. This is also a bit on the subject of referrals. Can you speak to when you make referrals to a home care agency?
So this is Dr. Katari. Home care agencies and all the different types of help they can provide are essential for our members, even when they're well. So a lot of them have functional impairments, but especially so when they get sick. And we try to sort of use them strategically from, we have partnerships to provide sort of heavy cleaning, chores, we call this independent ADL help, and even the case of as Deborah's case showed, I think really the medical part was important, but you could argue the most important part of keeping her home was ensuring through a PCA service, enough PCA hours to really meet her, hour by hour ADL needs.
Great. Thank you, Dr. Kazari. And thank you, everyone, for participating in the webinar today. We had a great discussion. And if you do have any questions after, here is a list of how to contact us in each of the different New England states. And I know Dr. Katari and Susan and Eileen included their contact information on their slides. We'd be happy to answer any questions you did not get a chance to ask on the webinar today. And also just to let you know, we are on social media, so if you want to see any upcoming events that we might have, you can check out our Facebook page, as well as we have some videos on YouTube, and I believe we are also on Twitter. So please reach out to us on social media, and I hope everyone enjoys your Thursday. Have a wonderful day, and thank you all to our speakers.